So our first talk is going to be about patient journeys in eczema, and this is going to be given to us by Professor Mike Cork and Dr. Simon Danby. And these guys work at the Sheffield Dermatology Research, which is really a real beacon of eczema care in the UK. So I've seen Mike talk many times, and I'm constantly impressed. He's obviously an esteemed dermatologist who has a real array of talent. So we see him looking in severe eczema. He's really pivotal in a lot of the clinical trials for new biologics and how we treat our severe eczema patients. But what I think is so great about this research team is that it also gives us information which is very relevant to the day-to-day person. We know that only a tiny proportion of our population will be able to see a consultant dermatologist and may be able to go to Mike and Simon's unit in Sheffield. But actually, they're doing research not just about the severe biologics, but also about what we can do on a day-to-day basis to actually try and prevent and treat eczema. What are the best things to put on your skin? What are the best moisturizers to use? Questions that really, as dermatologists in a busy clinic, we don't have time to answer. So I'm really looking forward to this talk. Mike and Simon, thank you so much.
It's an absolute pleasure to be here today, and really good to see so many people in the audience. Let's see if we've got my slides somewhere. The agenda, the afternoon agenda, that's us. Right then, on we go. So first of all, the most important slide, I'd just like to acknowledge everybody within our team at Sheffield. Mike's a clinician, I'm a basic scientist. We do lots of clinical research at Sheffield, and everybody here is involved in that work. I don't have a great deal of time today, so I'm just going to be scratching the surface on some of the things that we do. If anybody's got any questions, I'm here for the rest of the day, so please do come and ask. So we're talking about our most important journey, our journey through life. And you can see here in these images, and perhaps from a little bit of your own experience starting out on this journey, that our skin changes throughout our life quite visibly. And over our life cycle, we see changes in the prevalence of atopic dermatitis. Now, you'll all be very familiar with the fact that atopic dermatitis, eczema, it's a condition that mainly affects children. So we see that early peak in prevalence in the very young. But we also see an uptick in eczema in the later years of life as well. Now, what's really interesting is if we look at how the skin barrier relates to this, we can see it's a mirror image. So the skin barrier when we're born is suboptimal, and it takes a number of years to reach adult life function. And then as we age, once we hit around about 60, it starts to show signs that it's deteriorating. So what is the skin barrier then? Well, for anybody who doesn't already know, the skin barrier is formed by the intact stratum corneum, and that's the very outer layer of our skin. Now, the two key components to the stratum corneum, there's the orange blocks in that diagram there, they're the corneocytes, the terminally differentiated corneocytes, which form a key part of the stratum corneum. But what I'm going to be talking about today is the bit that goes between those corneocytes. So it's called the lipid lamellae, and it's a complex matrix of lipids, which includes fatty acids, ceramides, and cholesterol. And it forms, as you can see from the cartoon here, it forms this bilayer structure. It's very complicated. There are lots of different types of ceramides and fatty acids involved. And you can see an image here. It's an electron microscope image. We've got a corneocyte at the bottom and the top. And you can see this very dense lamellar structure running between the corneocytes. That's your lipid lamellae. And in that very intact structure, that's providing effective waterproofing for our bodies. That's what contributes to our barrier function. So we know that because we've done some experiments to test its function. And we do that using molecular spectroscopy. So this device here is an FTIR spectrometer, and we can hold it against the skin and take a spectrum of the skin to see what it's made of. And this spectrum along the bottom is typically what you would see. Now, we don't need to worry too much about what all those peaks relate to, but I would like to draw your attention to this one peak here, which represents lipids within the stratum corneum. And when we plot that peak, the shape and position of that peak relates to how densely packed the lipids are within the stratum corneum. And in healthy individuals, indicated by the blue bar here and the blue line, it tends to have a lower wave number position, and that indicates a very optimum orthorhombic structure of the lipids within the skin. But in eczema patients, what we see is a shift in the position of that peak to a higher wave number, and that indicates that those lipids are less ordered, they're looser. It's a more fluid arrangement. And the extent of that defect is related to the extent and severity of the eczema, but we still see it in cases where there is no visible signs of eczema. So it's very important that we address this defect in everybody, not just when the eczema is visibly present. Now, what's the importance of that? So this graph here shows the association between the structure of the lipids in the skin and the function of the skin as a barrier. So you can see when the lipids are intact, densely packed, we have the lowest transepidermal water loss, the best skin barrier function. And conversely, when the lipids are in a fluid arrangement, we see the highest levels of transepidermal water loss. So our bodies are losing more water, but importantly, it works the other way round as well. We see an increased risk of allergens and irritants gaining access to the viable layers of our skin. It also becomes easier for bacteria to invade as well. So if we look back at the age spectrum then, and we look at the skin barrier in infants, we can see that beyond some of the more well-established defects in the skin, like a reduction in natural moisturizing factors, there is also a reduction in the compactness of lipids. And that's in all infants. But in infants that go on to develop eczema, that defect is more extreme. And in this diagram here, if we look at the difference between healthy skin and the skin of individuals with established atopic dermatitis, you can see really pronounced lipid defects. And as I said before, ceramide lipid chemistry is really complex in the skin. So it's not just a general reduction in ceramides. What we're seeing is an alteration in the different types of ceramides in the skin. We see an increase in the very short acyl chain ceramides, like ceramide A, S, and NS. They increase. We see a decrease in the longer chain ceramides, such as ceramide ES, EOS, and also ceramides NP and NH. And that imbalance in the ceramides means that the lipids don't form that really compact lipid lamellae. And we see elevated transepidermal water loss. So thinking about the other side of the age spectrum then, as we get older, we also see some changes in the ceramide chemistry of the skin. So this data was taken from a group of individuals. They were all adults of various different ages, from 18 up to over 60. And the graph here plots, each dot is a ceramide species or subspecies. So you get an idea of just how many there are in the skin. There are thousands of different ceramides within the skin. The colour represents the class. And along the bottom axes, we have the correlation with age. And across the side axes, we have the correlation with skin barrier function. Now, the further away the dots are from the centre, the more they're related to age and skin barrier function. And there's a really clear pattern that appears. Lipids that appear in this bottom corner here all associate with young age and good skin barrier function. But the type of ceramides that appear in the top right, they all associate with advanced age and poor skin barrier function. And if we look at one of those, ceramide NDS, apologies, I don't know why that's not come out very well, but this just plots the correlation of one of those dots against age. And you can see that as we increase in age, and we've got individuals there, about 90 years old, we see a significant increase in the levels of this very short chain ceramide species NDS within the skin. And that's directly linked to the reduction in skin barrier function. So we know that at both ends of the age spectrum, we've got the risk of poor skin barrier function. There are challenges throughout our life that challenge the function of the skin barrier as well. So what do we do about it? Well, that's why we conducted the BRACE study. And this study is now being published in the British Journal of Dermatology, so it's in print and online if anybody's interested. I've only got time to show you the top line data today, but essentially we conducted a robust clinical trial, so it's randomized and controlled. It was observer blind to compare the effects of using a cream containing physiological lipids. So you won't be surprised to hear that that's CeraVe moisturizing cream. It's got an MVE base with ceramides, cholesterol, and fatty acids in there. It also has glycerin in, which is a skin humectant. And we compared that to a reference product, which was Cetraben. So at the time of doing the study, that was the most prescribed glycerin-containing emollient by the NHS. So this emulsion contains emulsifiers, emollients. It contains glycerin, so there are similar levels of the humectant glycerin as in the ceramide emollients, but importantly, no physiological lipids. Everybody in the trial was asked to use that twice per day for 4 weeks, and then we assessed the properties of the skin before and after treatment. So we'll quickly run through the results. So first of all, we looked at how this affected ceramide chemistry. Now, we did a big screen of all of the ceramides within the skin, but I've only got time to show you one of the highlight results here. So we're focusing on ceramide NP, one of those really positive ceramides for driving good skin barrier function. There was no difference compared to the baseline. So the baseline here is the dashed line. So with the reference product, no change in ceramide levels. But with the ceramide emollient, nearly a 40% increase in ceramide NP within the lipid lamellae matrices. So really important that we're delivering key ceramides to the skin. Next, we looked at how this affects the integrity of the stratum corneum. And you can see here, I think importantly, the glycerin reference cream had no effect whatsoever on the skin barrier. So traditional emollients are not doing anything to support improved skin barrier function. But with a ceramide-containing emollient, we see a significant 22% improvement in skin barrier function. And then, keep clicking the wrong button. And then lastly, if we look at the water content of the stratum corneum, so how moisturized the skin is, we can see that both treatments increased the moisturization of the skin. That's as expected. They both contain humectants, glycerin, but there was a 25% increase in the amount of moisturization within the skin when using the ceramide emollient, showing that repairing the lipid lamellae also contributes to how effectively the skin stays moisturized. And then next, we looked at the effect of these treatments on the sensitivity of the skin to a common irritant. So sodium lauryl sulfate, it's something we find in shampoos that we use regularly. It's a known irritant, and we challenge the skin before and after treatment with 1% sodium lauryl sulfate under a patch and compared the response. So we've got the graphs here. If anybody wants, just to show how robust the data is, but I'm going to focus on these images which show the results of the study nice and clear. So we've got the baseline sites here that have been patched. These were all individuals with a history of eczema, so they all show that response to sodium lauryl sulfate. We've got that strong erythema because they've got a weak skin barrier. After treatment, however, 4 weeks of treatment with Cetraben had no effect on the skin's response to sodium lauryl sulfate. But you can see a really striking reduction in the erythema, the irritation caused by the challenge with SLS when we've used the ceramide emollient for 4 weeks. So it's protecting the skin from irritation from a common household irritant. And then lastly, I just want to run through a couple of studies that just exemplify the clinical relevance of this finding. So first of all, there are a couple of studies that have been conducted now to show that if you use a barrier-strengthening emollient during that period of remission, so once you've achieved control of the eczema, you can reduce the risk of relapse by 40%. Next, I wanted to mention the BEEP study. So you may be familiar, this was a study in infants conducted a number of years ago by the Nottingham team, and they set out to establish whether prophylactic use of an emollient from birth could protect against the primary development of atopic dermatitis. So addressing that skin barrier defect that we have in those first couple of months of life, on to years. Now, they used a range of emollients that were currently available in by the NHS. So none of those have skin barrier enhancing properties. And it was no surprise to us that there was no preventative effect. It had no effect on the risk of eczema. But I'm really pleased to share with you that this year, a new large study has just been published. This was conducted by Eric Simpson's group in America, a very similar study to BEEP, where they looked at the prophylactic use of emollients in babies from birth. But importantly, this time they used barrier strengthening emollients. CeraVe moisturising cream was one of those emollients, and they found a significant reduction in the risk of developing eczema with regular emollient use from birth. So just bringing home the fact that using these barrier strengthening emollients can protect against eczema, both its initial development and future flares. And I have just given my summary there. So skin barrier is very important, particularly the composition and structure of the lipid lamellae. That determines how well our skin functions as a barrier. We need interventions at all stages of our life to ensure this barrier functions at its best. And we've shown today that using a topical therapy can correct that lipid defect, and that results in a reduction in the risk of atopic dermatitis. So with that, now I'd like to hand over to Mike, who's going to share some fantastic patient stories with us. Thank you all for listening.
Thank you very much, Simon. Thank you, Emma, and thank you very much, L'Oreal, for the amazing partnership. I'd like to first bounce off Simon describing the Cascade trial. So that trial showed that using CeraVe from birth prevented the development of atopic dermatitis. But as Simon pointed out, the BEEP trial led by Hal Williams using a basic emollient didn't prevent atopic dermatitis. But what Simon intentionally left out was the adjuvant effect of combination therapy in the Cascade trial. It was possible to substantially increase the effect of CeraVe in preventing atopic dermatitis by adding a dog. And Emma, Simon, and myself was discussing this. It was an incredible effect. The dog in the house significantly increased the effect of CeraVe in preventing atopic dermatitis. So Hiba, we now have the next trial for you. This is what Emma, Simon, and myself think. It's woof for brace. And we look forward not only to conducting a combination trial of dog therapy with CeraVe, but presenting it to you in this lecture theatre with all of you, CeraVe, and all of the dogs. Something to look forward to. These are my disclosures. With great respect, please do not take pictures of the clinical images, as I brought along some of my co-presenters. So, we think of emollients for mild, moderate, and the mild end of the AD spectrum. We don't think of them for severe AD. And we want to try and challenge that perspective. So is CeraVe only indicated for mild, moderate AD? So it's been a wonderful 10 years. We have had the biologic drugs for atopic dermatitis, and it's been life transformational with dupilumab, tralokinumab, Lebri, and now Nemo. And we've been very privileged to be involved from the very beginning with the dupilumab trials. And I'd just like to share with you some of the stories in those trials, looking at fantastic responses, and then looking at partial responses to biologics and why they occur. So this is Harry. He was the first child in the world to be treated with dupilumab in the first trial in our hospital in Sheffield. And Harry had a horrible life, if you just read Harry's story. I don't think we can ever present this story too often because it's so impactful. He almost died from MRSA septicemia in intensive care in Liverpool. And then he got in the first dupilumab trial, the first trial to be treated in the world. I remember the night before thinking, oh, geez, I'm going to give the first child a biologic drug. But we didn't need to worry. And the effect was absolutely incredible. But perhaps the most incredible thing was what happened to Harry in 2.5 years. So at the point we started the trial, he was one of the most severe children with AD in the world. And a year later, and 2.5 years later, he came off dupilumab. His IgE was 155,000 when we started the trial. And Fiona Shackley, my paediatric immunology screen, obviously screened him for hyper IgE, all negative. It was all due to AD. And he went into complete remission, and we think this is one of the first demonstrations of disease modification with dupilumab. And we're now planning clinical trials from 6 months old with dupilumab to try and disease modify, prevent food allergy, and prevent asthma. Oh, and I saw him a few months ago. Oh, and these are the AD brothers. Imagine being their parents. And Theodore got in the dupilumab 6 to 11 years trial. Zachary got in but had to come out because of needle phobia. And Sheda Shib, our paediatric psychiatrist, got him over it with CBT, but of course he wasn't in the trial. And Barnaby missed it by 6 days because of his age. And I've got a friend in Regeneron called Brooke, and I showed him this picture and said, well, we need to get the other 2 boys on dupilumab. He said, don't worry. Just email it to Len Schliefer, the CEO of Regeneron, and text me when you send it, and I'll walk round to Len's office. Well, he didn't need to walk round because Len replied within 20 minutes and gave compassionate use to the other 2 boys. So we have had some amazing dupilumab stories, and the other biologics are obviously delivering the same. Dupilumab was just there first. But responses to dupilumab decrease with age. So if you use dupilumab at 6 months old, it's got about a 99% chance of getting an EASI 75 at 16 weeks, and EASI 90 by 6 months, 99%. But it falls off with age. And as we all know in adults, it's fallen off quite dramatically. And you see different responses. So you see complete responders, partial responders, and no minimal responders. One thing we've recognized is facial-centric residual erythema on biologic drugs for atopic dermatitis. And this, as we know, is very heterogeneous. Some of it's rebound from topical steroids, some of it's vascular hyperreactivity, and some of it's incomplete repair of the skin barrier, and some is superimposed allergic contact dermatitis. This is a patient I sent to Catherine Holden, who cleared on dupilumab and then developed this. And Catherine showed she was allergic to cetosterol alcohol, which was in every single cream she was using. Let's focus on incomplete repair of the skin barrier. This is a phenomenon we've been recognizing on dupilumab, and of course, by extrapolation, with every other biologic drug. It may take a very long time to completely repair the barrier. We may clear the skin on the surface, but the barrier may take a year, may take longer to repair. So does the skin barrier return to normal when we treat with dupilumab? This is the Pelistad trial, and it's a trial funded by Regeneron Sanofi looking at dupilumab in children 6 to 12 compared with untreated controls, and we measure everything in terms of their skin barrier. And this is something called optical cohesive tomography. It's taking a virtual skin biopsy through the skin, totally non-invasively. And you can see little Charlotte, who's only 6, not a problem. We have also conducted OCT on teddy bears, I should hasten to add. Now, this is Charlotte's picture of herself before dupilumab. I love this. Very painful, hide my arms. And her picture after dupilumab. But we've cleared her skin on the surface with dupilumab. What's going on in the skin barrier under Charlotte's beautiful picture? Has it returned to normal? Well, the answer is no. And this is a study we presented at the ADV last week. Our main collaborators are Donald Leong in Denver. And what you're looking at here is the recovery of transepidermal water loss on dupilumab. And you can see lesional skin, non-lesional skin, and they are both recovering in parallel by 28 weeks. But look at the difference between normal skin and non-lesional and AD lesional. It has not got back to normal skin. So we have a residual skin barrier defect on dupilumab at 28 weeks. And Simon produced these beautiful infographics that show you what happens to the lipid lamellae. It is disordered in AD and highly ordered in normal skin. Dupilumab is bringing it back towards ordered, but it doesn't get all the way to super-ordered normal skin. So we have a residual skin barrier defect, even though Charlotte's skin is totally clear on the surface. And as Simon showed, there's a very good correlation between the ordered and disordered lipid lamellae and barrier function, such as transepidermal water loss. So, dupilumab treatment for 28 weeks does not restore lipid chain to normality. It is still slightly disordered. And so, these are patients with moderate severe AD on dupilumab, and we've cleared their AD, and it gives us a rationale for adjuvant CeraV therapy on top of dupilumab. And it's rather a nice sort of serendipity story, because what happened, lots of patients were coming to our clinic and they'd actually found out about CeraV and were using it with dupilumab even before we suggested it. And then we can just basically bring the skin barrier back to normal. We're now conducting Pelistad out to 2 years to see whether dupilumab on its own brings the skin barrier back to normal. But what we think is really important is just going back to the basics of dermatology, not totally relying on the biologic drugs, but nurturing the skin barrier with what we call level 3 emollients, CeraV, rich in ceramides, to try and accelerate the barrier recovery underneath the surface of the skin. And basically, normal skin, AD on dupilumab, we have a partial skin barrier defect. We don't have a complete repair of the lipid lamellae, and that gives us an opportunity to add CeraV therapy in these patients with moderate and severe AD. So in conclusion, I started with this question, are level 3 emollients, CeraV, just indicated for mild, moderate AD? Definitely not. Based on this study, the dupilumab Pelistad study that Simon, myself, and Donald Leong have conducted, we can see that there is a residual defect in the skin barrier even when the skin is clear. So it has disordered lipid lamellae. It hasn't gone back to normal at 28 weeks. And this gives us a rationale to add CeraV therapy to dupilumab to try and accelerate the barrier recovery back to normal. maybe in some patients this will help reduce or prevent facial centric residual AD. Of course it won't prevent it in all patients because it's very, very multifactorial. So CeraVe is also indicated for residual skin barrier defect in patients on dupilumab therapy. And I'll just go back to Simon's slide for the BRACE study. All emollients are not the same. They are totally different compared to this oil in water plus glycerin is Cetraban, this is CeraVe, and you can see substantial improvements in barrier repair with CeraVe compared to Cetraban. It's all about barrier repair, and it's all about the correct formulation. Not all emollients are the same. It's all about the formulation, and maybe the dog. Thank you very much.
Thank you so much, Simon and Mike, and Simon for explaining all about the skin barrier, how we can prevent it, and then Mike for really bringing that to life with our patients. So we've got some time for questions, if anyone has. We've got a roving mic here, and we also have a QR code which you can submit questions to for the whole day, actually. So if you want to scan that, then please do. But any questions that we have here? So while you're thinking about your questions, I have some questions. So Mike, we were sort of briefly talking before that always when people have got very severe eczema, the learning and the thinking has always been just cover them in 50-50 as an ointment. Why have we done that? And should we continue to do that? What are your thoughts on that?
I think in very severe erythrodermic AD, I use that phrase, going back to basics. Use the most basic formulation with the minimal ingredients. You don't want any emulsifiers, and so that's exactly where I would use 50-50. But at the other end of the spectrum, Simon showed you the Cascade trial and didn't have time to show you, but ointments in the Cascade trial, ointments did not prevent AD. No prevention whatsoever. And Peter Elias back in the 1980s showed if you put ointments on skin barrier which has a minimal defect, you can actually delay its recovery. So it's all about tailoring, absolutely, as we've always done, tailoring the formulation to the severity of the AD. And prevention, mild, moderate AD are totally different from severe AD.
Fantastic, thank you. One other question I also had, Simon, I really loved the graph of how our skin barrier changes over time. I have an interest in adolescent dermatology. Do you think there's anything around the teenage skin and the teenage skin barrier that is different to any of the other age groups?
Yeah, absolutely. I mean, as you see, it seems to be a protective period where eczema is concerned, but obviously that's when acne develops, and I mean there's a skin barrier element to acne as well. So it's not functioning well, but during that period you've got a lot more sebum production, and so that's changing the dynamic around that period of time. Sebum's very moisturising, so that may be protective then of developing the eczema, but obviously it's contributing to the acne. So yeah.
Interesting. Swapping one problem for another.
Yeah.
Very good. Was there a question?
Hélène Maniget, is this something you've looked at with ceramide emollients other than CeraVe? My question really being, is this entirely to do with ceramide, or is it to do with the way the ceramide is released? Because I believe that with CeraVe there is a slow release formulation.
Yeah. I mean, it's going to be a combination of the two because the CeraVe is built on the MVE, multivesicular emulsion technology as well. So there's a different delivery system there, and we're showing that system is able to effectively deliver the ceramides that are needed into the stratum corneum matrices. we do know that some of these lipids don't penetrate the skin very well, so they can be applied to the surface of the skin and they'll just stay there unless they've got some encouragement to penetrate further down. So it's a combination of the two. So unfortunately, we can't just relate the results we've seen for CeraVe to all other ceramide emollients because they're not going to have that same formulation. It's important we test emollients.
Emma, can I bounce off you? Acne, AD, and teenagers, pretty difficult combination. I love patient stories, and this is an amazing one. I got sent a picture by a friend of their granddaughter with horrendous acne. I thought, oh, she's going to need isotretinoin. And they said, well, will you just have a chat with her? And I said, yeah, sure, no problem. And it was, you know, that list they come out with, all the things they're using. It was, well, on the chat, it was several pages. And of course, I looked at the formula. Oh, no, you know, highly comedogenic substances. So bear in mind, I'm thinking of using isotretinoin, and then I read all of this. So I said, well, why don't we just stop everything, and then we'll use something very specific. And I went for a CeraVe acne wash. So I thought, I want something really mild. I want a bit of exfoliant. I want to break down the hypercornification. And then I said, why don't you use the CeraVe acne gel in reserve? So I'm trying to get the balance correct. Anyway, she sent me some pictures a couple of months later. Complete clearance. And I think the message there to me is always about the history in dermatology. If I'd just given her the CeraVe wash and the CeraVe gel, and she put that on top of all of this complete rubbish that she was using, I don't think it would have got through. But by taking the history and getting rid of all the rubbish and then putting in some good products, an incredible response. And so I just think we get, teenagers are always challenging, aren't they? But that, I couldn't believe it was the worst I'd ever seen in terms of the number of products she was putting on her skin.
I mean, teens are some of the biggest consumers in Sephora, Space NK. You know, on social media, these 8 and 9-year-olds have a get ready with me. They've got a beauty fridge. They're putting on different types of retinoids, all sorts of things. I mean, this is what we see, the reality in clinic, and people are buying them, all of these different products. So you're absolutely right. In that age group, to try and engage them, educate them, and actually ask about what they're doing, because often there are balm cleansers, oils, all sorts of things going on the skin. So really interesting. One last question I had was around NHS funding of ceramide-based moisturisers. Where are we at? What are the issues for the average payer? So if you're sitting in clinic and you're saying actually what you need is a ceramide-containing moisturiser, are there any options that we can do through NHS?
Not currently.
Well, we have a dream that one day CeraVe will be available on prescription. Yeah, maybe dreams do come true sometimes. Yeah, we can dream, can't we?
Perfect.
And I have CeraVe and a dog.
Dogs on prescription. Anyway,
Yeah, absolutely.
thank you so much. That was absolutely brilliant. So thank you very much.